Good morning. What Dr. Vanderwagen neglected to say is that I had 3 great years working for him when he was the ASPR and kicked off and built the organization back then when it started in 2007, and cherished that time that I had with him for his leadership, for his knowledge, and his willingness to let people grow and expand into ways and new grounds that previously were not yet fully developed. So I appreciate that. I bring the regrets from the current ASPR, Dr. Kadlik. He can't be here today, but I think you all have the pleasure of hearing him wind up the workshop tomorrow morning as he provides concluding remarks. I think you'll all enjoy what he has to say in getting an opportunity to talk with him. Again, the usual thanks to the Planning Committee, the Academy, for making this happen, and thanks for all of you for attending. This is an important topic. May not be the most glamorous thing that we talk about during disasters, but it's one of the most important things that we'll talk about. ASPR's mission is to save lives and protect Americans. It was the mission when it first stood up, and it's still the mission, and that's what we take that seriously, and we take that to be a very meaningful mission, and ultimately everything we do in ASPR is focused on that public health and medical encounter that occurs in the field at the local level, and trying to help that individual provider take care of that individual person who's life has been changed because of a disaster, most likely not to their doing or their cause. So that's what we focus on, and every day we go home thinking how we've advanced that cause. ASPR is really set up to provide unity of command in the health field, the federal side of the health field. After Katrina, the results of that from the health side, the planning wasn't great. The response had a lot of areas for improvement, and ASPR was put together by Dr. Kadlik and a host of other folks to address the unity of command. Not unlike the combatant command set up in the Department of Defense. ASPR is responsible for mustering the federal resources to address, to prepare for, respond to, and recover from disasters, but we're also there to empower state, local, tribal, and territorial jurisdictions to handle as much of that as they can and empower them to take care of their local needs. Because again, the dictum is true, all response is local, as is all preparedness and all recovery. We view ourselves as the organization that assists them in their time of need and helps them prepare for events. And there's a lot of areas that ASPR covers that relate to the topic at hand. Our Biomedical Advanced Research and Development Authority does just what the name says, advanced research and development for medical countermeasures that we hope will get licensed and end up in the stockpile for use in a time of need. We also manage the Emergency Support Function 8 responsibilities, public health and medical services, under the National Response Framework. And the range of those 17 responsibilities is everything from environmental health to mortuary affairs and everything in between. So we do potable water, we do medical care, we do environmental health, all those aspects in that. We use our National Disaster Medical System, our Hospital Preparedness Program, and our Medical Reserve Corps programs to help do that and to help empower states and locals to meet their missions. But again, this will be a recurring theme that I talk about today is we can't do this alone. We have dependencies. Just like the supply chain has dependencies, just like production has dependencies, just like our private partners have dependencies. We have dependencies. First of all, we depend on our HHS partners and our federal partners. FDA, who has an important role in what we're going to talk about over the next day and a half. Centers for Disease Control and Prevention, another important partner for us, as is CMS. CMS is an important partner in this with regards to reimbursement for supplies, equipment, and medications. But we also work outside of HHS with Department of Homeland Security and FEMA. We also have public partners. We partner with public health departments across the nation, states and local public health departments who have an enormous responsibility to take care of their communities and provide guidance and response assets for their communities in times of disasters. We also deal with emergency managers and law enforcement. So we're dependent upon them for making sure that when we deploy, our teams are safe and our teams are set to accomplish missions that the state and locals want us to do. We also have private partners. And some of you are in the room. And we view those partnerships from the pharmaceutical industry, from the healthcare industry and healthcare systems. Non-governmental organizations are all important partners, as is academia. And we rely on academia to help us think through some of the innovative concepts that we need to apply to problems like this. And I'd be remiss if I didn't mention emergency medical services. Okay. Again, emergency medical services is a key component of our healthcare system. If you think of that spectrum of healthcare from the first responder, the citizen responder, who applies a tourniquet, getting them to EMS, keeping them alive so EMS can perform their wonders on those patients, get them to a hospital safely. In difficult situations, in a bad, sometimes hostile environment, get them to the hospital safely. And then the hospital takes it from there to get them rehabilitated and get them back to be a productive, functioning citizen after the event. So those are our dependencies. And again, I don't want to not mention how we address those partnerships with private industry. ASPR has what we call our critical infrastructure protection program, and Laura Wolf, who's in the audience, runs that program and has run it for several years now. And we bring our partners in before disaster, and we talk about what we need, how we do business, invite them in and let us see that, talk to them about what they can add to that, and work with them on a partnership basis to understand how they do business, how we do business, and how we can work together productively to address the complex issues we all face in disasters. Not just the problems we face, we all face those problems. But we're also dependent on other things that may not be as apparent as some of the relationships we have with the healthcare industry. We're unbelievably dependent upon power, electrical power. Our healthcare system is putting more people on medical equipment at home, on equipment that's dependent upon a reliable and good power source. Our hospitals are incredibly dependent upon strong power source and a reliable power source. And of all the things that bother me the most, and have bothered me for years the most, is that hospital that's on a generator. Because they're really vulnerable, and evacuating 200 or 300 patients in the middle of the night hastily is a complex operation. And it puts the patients at risk, it puts staff at risk, and it's not the best environment. So we're incredibly dependent upon power, as is our production industry. We're dependent upon transportation. We can make the stuff, we can put it in a warehouse, but if we can't get it from the warehouse to people's veins, it's not going to work. We need to get that whole system, and that depends on an intact transportation structure. And we lose that in hurricanes temporarily. We're probably going to lose that in earthquakes more than temporarily. So how do we move things? How do we get stuff from the warehouse to the circulatory system? And again, water systems. Again, you think, well, we can bring in bottled water, we can do this kind of stuff. But if you're that end-stage renal disease person on dialysis, you need a good water supply. And again, it's much easier to bring stuff in than it is to move patients. But if we have to, we move patients to where the sources are. So again, you go from a spot shortage or a local shortage, which is easier to address than regional or national shortages. And then, and also want to make sure that we address our entire population. 20% of our population is what? Pediatrics, Steve, right? About 20%. We need to make sure that we're not just thinking of the adults in the community. We're thinking about the kids. We want to make sure that our shortages don't include artificial shortages like, oh, geez, we didn't think we would need pediatric equipment, or we didn't think we needed to put pediatric medical countermeasures in the stockpile. We have to address that, and we have work and partnerships with our pediatric colleagues to try and do that, and they make sure that we don't neglect that part of our population. That's very important to us. So, our day-to-day function in ASPR is we deal in shortages. That's what disasters are. There's a demand that exceeds the supply. That may be a temporary one-day thing, that may be a 2-week thing, or that may be months on end things that we have to deal with. So this is not unfamiliar ground for us. We have to think in those ways, and we do that in a number of ways. We can stockpile equipment and supplies. We can provide guidance that helps people use alternatives. ration, stretch out clinical guidelines, so you give medications less frequently, things like that. But we can also look at things like standards of care. And in a real national crisis, we're going to have to address that. And again, probably not a topic for the next day and a half, because we could talk all week on that, and the National Academies has done a lot of work in that area. But it's a discussion that communities have to see how we're going to deal with those events that the demand far exceeds the supply we have on a national level. So disasters cause shortages. We know that. We live in that world. But what we have to address, and again, at least part of the discussion today has to be on how do the day-to-day shortages that we experience impact our ability to respond in a disaster. And if a community on a day-to-day basis is already using Plan B to address a shortage, and there's a disaster, and Plan B is kind of what we have in our hip pocket to use, and it's already being used, we have to think a little bit more, we have to think a little bit harder, and we have to address that. So, as has been said many times before, the daily performance of our healthcare system really has an impact on how well we do in disasters. And that's true with emergency department overcrowding, that's true with shortages. So we have to be able to address that, and I hope in your discussion today and tomorrow you talk about that in some regard, because it's important to us. And again, we're not the lead for the day-to-day shortages. That's the FDA. FDA does that, and they've really taken the lead on this issue. They have some authorities that they've been applying to drug shortages that have really helped, and they've done an exceptional job. I think since 2011, the number of new drug shortages has steadily decreased. I think it's like 40% of what it was in 2011. They've done some other things, and most recently in July, the FDA commissioner has established a task force on drug shortages to help address those issues. And the causes are many. You'll talk about those as you have your discussions today, and I'm not going to go into those. But we have to also remember that we live in a global market, and a disaster in another country may impact what we receive in our production lines and in medical countermeasures. It may impact our equipment supplies. So we have to worry about the global market, not just our domestic market. And that includes factors, economic factors that may raise the price, may decrease production, and may impact the supply chain. So we have to worry about that. We also have to worry about competition. We're not the only ones purchasing these things that are produced overseas or offshore. And there's a global market for the things that we're interested in, and if there's a limited production capability, we're going to be in competition with partners and others for those products. So again, just summarize is, this is not just a federal responsibility. This is a public-private responsibility with a focus on partnerships. Picking up the phone and calling someone and trying to plan, it's pretty cheap. It can be done pretty easily, and we encourage that, but want to focus on the public-private side. We'll do our part on the public side to try and foster those conversations through programs like our CIP program and others, but we want to have those discussions. Convening meetings like this and looking at the list, it looks like we got a lot of the right people in the room, and certainly a lot of smart people in the room to address these things. We want to look at root causes to make sure we're identifying the real problem and not just a cosmetic problem. And then, most of all, we want to think of innovative solutions. Working harder just isn't going to help for a short period of time, but we need to be smarter. We need to be innovative when we think of solutions of how we're going to address shortages during disasters. So I'll leave you with that charge, and we'll stop there and turn the floor back over to Admiral Van der Wagen. Thank you.